Hello, thank you for joining us today. My name's Sam Carter and I'm the International Product Specialist for Rayner. And joining us today, we will also have Mr. Alon Barsom, who is a leading corneal consultant in the NHS in the UK and also a founding partner of OCL Vision. So RayOne EMV, it's a monofocal lens first and foremost, but it's providing extended range of vision. And it's optimized for use with Monovision. That doesn't mean it has to be used with Monovision by any means, but it is the only lens on the market specifically optimized to be used in a Monovision setup. It was launched in October 2020 in CE mark accepting countries, and many other markets will be able to use the lens this summer when it is registered all around the world. Thank you again for how many are joining. We're already well over 200 participants. We have 600 registered from 37 different countries. And thank you for taking your time, 45 minutes out of your day, and I hope you'll find it very interesting. So RayOne EMV is part of Rayner's range of preloaded lenses. RayOne is the name of our patented injector, which is a true two-step injector, extremely simple to use. If you'd like to see some great surgery videos, please visit our YouTube channel, which is Rayner IOL. If you just type that into YouTube, you'll be able to see very many really smooth implantation videos. It truly is the best system on the market. And you can see here the EMV sitting in the monofocal category, because it is at heart a monofocal lens first and foremost, but with some serious benefits. So what are those? Well, it's providing extended range of vision, which will allow much better intermediate vision than you would get with a standard monofocal lens. Around 1.25 diopters of extended range of vision. This also has the benefit of making it more forgiving of missed target refraction, because it has a larger sweet spot where patients will still achieve 6/6 vision. And the way it works is that it complements the eye's natural positive spherical aberration. So almost every eye and cornea will have a level of positive spherical aberration, and this lens is enhancing and increasing that slightly to increase the depth of focus. The lens is designed to be very forgiving of different pupil sizes and centrations, decentration and tilt, very different from multifocal lenses, but also different from many of the competing extended range lenses, which often have a small zone in the center, which is doing all the work of extending the range of vision, and then a normal section outside, which is the same as a standard lens. That's not the case with the RayOne EMV. As I've already mentioned, it is optimized for Monovision. And what that means is that the zone between the distance and near eye is blended, and it's a smoother transition. The two eyes are able to work together, giving the patient binocular vision more of the time than they would have with a standard lens in a Monovision setup. And this also reduces the chance of subjective patient complaints from the Monovision offset, asthenopia, headaches, etc. But always designed with that excellent distance vision in mind, so that with an offset of up to -1 in the near eye, we still expect excellent distance vision of 6/6 or 0 logmar, even with that Monovision setup. The interesting thing is that because of the way that we stretch the focal point, even with an offset of -0.75 or -1, that near eye will still contribute slightly to the distance vision, very different from with a standard monofocal lens. You can see down here the extended range of vision when you use a lens with no Monovision, around 1.25 diopters. And of course, this will increase in a linear fashion if you add Monovision to the setup up to -1, you'll get 2.25, and you can, of course, have a larger offset than that if you're comfortable with this from previous experience with Monovision. Now, the idea for this lens and the patent actually came to us from Professor Graham Barrett, who is a long-time advocate of Monovision as a very effective method of correcting presbyopia, but realised that there were some limitations to Monovision with standard monofocal lenses, and brought this idea to Rayner and worked with our R&D department to hone the design, and he's very happy with the final result. Looking a little bit more detail at the optic, you won't see anything very interesting, and you won't see under the microscope either. It will look just like a normal lens. There are no zones, no rings, even faint rings or anything like that. It will look just like a normal lens, but actually it's very subtly but very importantly different, with extra positive spherical aberration in the center, gradually reducing towards the outside to reduce the loss of contrast that you would associate with high positive spherical aberration in the periphery of the lens, as you have with an old-fashioned spherical lens, for instance. With the EMV, it's very cleverly attenuated so that the patient will still have excellent quality vision with all pupil sizes. And this is really the heart of why the lens is able to deliver the increased range of vision without dysphotopsias, giving high patient satisfaction for a broad range of patients. Clearly, there are lenses out there that will give stronger near vision, trifocal lenses, of which Rayner, of course, have one. But they, of course, have other compromises to them, and not every patient is demanding absolutely perfect near vision. And for most patients, an extended range of vision is very attractive. So look at a little bit more detail, comparison with a standard lens. So this would be a negative aspheric lens compensating for the average cornea. This is from an optical bench test with a model eye with an average cornea with the normal level of positive spherical aberration being counteracted by the negative aspheric lens. And so you get a perfectly even curve targeting 22 diopters for distance. And you can see that the vision will drop off quite quickly either side if you do miss target refraction. And hi, Alan. nice to see you. So in contrast, when you see the EMV curve, the first thing you'll notice is that the peak is actually somewhat over to the right. And this is a feature of the positive spherical aberration and is what we expect and is what you should expect to see. This is a -0.5 diopter refraction compared to target, but with a very tiny drop-off in vision at the distance plane. And what this means is you're able to access this really useful area here under the curve of intermediate and distance intermediate vision, and for some patients, even near vision. The whole point behind this lens and many of the other lenses on the market is that it's long been known that you don't need to chase the very highest possible MTF curve to deliver 6.6 or better distance vision. And in fact, it can be just an unnecessary waste of this vision up here when you can make it a lot more useful for the patient by stretching this curve somewhat. Now, this shape of curve is unique to Rayner because we have the patent on positive spherical aberration. If you look at another competitor lens attempting to extend the range of vision using negative spherical aberration, so going against what is in almost all corneas, you can see that, of course, they will get a little bit more range of vision in the intermediate area, and the vision and the curve is stretched towards intermediate and near. But overall, there's a lot more area under the curve on the useful side of the distance line with the EMV. Looking at another competitor, still able often to get 6.6 for distance, even with the MTF significantly lower for distance, more like a trifocal lens, in fact, for distance. But as we know, you can still achieve 6.6 distance vision with these lenses. Trying to achieve a larger stretch and more near vision, but clearly at a greater compromise to the overall level of vision at most distances. So this graph, I hope, will make it clear that the lens can work extremely well when used as a standard lens with emmetropic target in both eyes, when you would see significantly better intermediate vision, some patients getting good near vision, excellent distance vision, and a really nice overall patient satisfaction profile. But when you look at the lens in a monovision setup, this is why where you can see why our lens specifically works brilliantly with Monovision. Because the near eye here, in this example, it's minus 1.5 target, is crossing over a lot with the distance eye and allowing binocular vision in this blending area here, and less of the time that the patient's only using one eye for distance and one eye for near, which is what most people think of with Monovision. So if you look at with a standard monofocal lens in the same setup, that's what you would get, really: one eye for distance and one eye for near, with very little crossover. And also a noticeable trough in between the distance and near, which patients may notice and not be that comfortable with, because there's an area of vision which feels a little bit blurry in between their best focus for distance and near. Of course, the whole point of Monovision is that you consider the vision binocularly. So when you consider it binocularly, what you'll get is the near eye pushing up the distance vision to a level comparable with any monofocal lens on the market. So a simplified way of thinking about it is that the lens allows you to have two eyes for distance and one eye for near, instead of one eye for distance and one eye for near. So this near eye being able to help the distance vision, as I say, is unique to us because our curve is stretched back towards distance rather than off towards near and intermediate, allowing the most important distance for almost all patients and doctors, distance, to be prioritized. Another simplified way of thinking about the advantages of RayOne EMV compared to a standard lens in the Monovision setup is you'll definitely straight away appreciate, if you use the lens, that it has a significantly better range of vision towards near. You'll also, after using the lens for some time, appreciate that there is more subjective, positive comments from the patients about their Monovision, because there's a better, more comfortable blending zone between the two eyes, and there's much less of the time where one eye is working on its own. And as I mentioned, the near eye up to -1 target can actually still contribute somewhat to the distance vision. Clearly, it will not be 6.6. But it will still give some useful imaging performance up to -1 target, which is, of course, completely at odds with what you would see with a standard monofocal. So where does the lens sit in the pantheon, ever-growing pantheon of lenses and descriptions and technologies? This is my own slide trying to simplify it somewhat. A lot of these terms are interchangeable. They're not often defined, and they're somewhat confusing in many cases. But you can see over here on the left-hand side, monofocal lenses, leaving almost every patient dependent on glasses for some of the time. And on the right-hand side, the trifocal lenses, delivering almost always spectacle freedom, but as we know, at with other compromises, which have to be discussed at length with the patient, of course, in order to achieve happy patients. Clearly, RayOne EMV is going to be somewhere in between, but exactly where in between depends on how you use it. If you use it with no Monovision offset, it's going to be competing with the extended range of vision lenses down here, rather more range of vision than you'd see with a monofocal plus like iHance. And then as you start to increase the level of Monovision, you can get to ranges of vision to compete with these low-ad multifocal lenses, which are often termed EDOF rather confusingly. But in fact, as we know, these lenses have rings and these lenses have zones and are multifocal, all multifocal, and therefore have some of the compromises and trade-offs and dysphotopsia discussions that you would have with a multifocal lens. So if you're able to compete with those lenses in terms of range of vision without having to have those discussions about dysphotopsia, it's a really nice place to be in. So in summary, it's an extended range of vision lens. It gives excellent distance and very good intermediate vision when you use it just like a standard monofocal lens, targeting emmetropia in both eyes. But it's optimized for use with Monovision. The level of Monovision is up to you, but it really does work even better, we believe, with some level of Monovision, because you don't have the downsides that are associated with Monovision. The distance eye should always target emmetropia, or close to that. Obviously, you can then develop your own exact targeting once you're very used to the lens. And the near eye target, as I say, it's the doctor's choice. If you're used to using higher levels of Monovision, then you can use exactly the same with EMV. If you're not familiar with using Monovision in the past, as I say, you can use it as a standard lens or anywhere in between. It can be used on almost any healthy eye in place of a standard monofocal lens. Astigmatism allowing at the moment. Toric is in the pipeline, but at the moment we do recommend post-op cylinder to be less than 1 diopter. There's no additional visual side effects from this optic, halo and glare, etc. So it's really very easy to incorporate in your practice. And as I mentioned already, you should expect to see a post-op refraction around -0.5 diopter from where you targeted, and this should not be adjusted for. This is the lens working as it should, which will be quickly apparent if you put the patient on the chart and get them to check their distance vision. They may be showing -0.5 or -0.75, but their distance vision will tell you that this lens is doing something very different from a standard monofocal lens, where you wouldn't expect very good results in that situation. So I've said it before, but I'll say it again. Really, if you do want to use RayOne EMV, you should start using it as you feel comfortable, and whether that be with or without Monovision, and if it's with Monovision, whether it's with a small amount or a large amount, that's completely up to you. So that's all from me now, and I will hand over to Mr. Alan Parson.
Thanks very much. Thanks very much, Sam. So I'm going to talk about premium lenses, more benefits for more patients. These are my affiliations. I'm a consultant for Ray now, including several other companies as well. So Sam's covered this briefly, but I think it's helpful to look at the kind of newest classification for premium lenses, just to have that in mind when we think about this lens and other lenses that are available. Very brief overview of the most commonly lenses currently available to address presbyopia. I'll talk about pitfalls and patient selection, but the focus of this talk is on the latest premium monofocal, namely the RayOne EMV, and there will be time for questions which you can do as you go along. We'll try and answer as many as we can during the talk, and there should be a little bit of time at the end as well. So the first thing to say is that for those of you not addressing presbyopia in your patients, you and your patients are missing out. We no longer live in a distant dominated world where kind of fighter pilot distance vision is the priority. Now people have to look at their screens for everything, computer screens on cars, including even airplanes now. Drone operators are working on screens. We're all on our smartphones all the time. So uncorrected near vision is very important. And then glasses, especially in the pandemic with mask wear and contact lenses, all have their own issues. So the opportunity for relative spectacle independence and an appreciation and planning for some level of near vision is of huge benefit to your patients. And if you benefit your patients, then that will result in more patients, providing that's what you want. This is an excellent article that was published recently in Cataract and Refractive Surgery Today, Europe, about lens terminology that I recommend you read. And essentially, it categorizes lenses according to mechanism of action. The lens we're going to talk about today doesn't fit into any of these categories. It would come into other as it works via spherical aberration. But it's always important to think about the mechanism of action of the lens. Don't use a lens because you're told that it's an extended depth of focus, which is a very confusing term. Rather think about exactly how that lens works. And I think it's helpful to, again, I think the term monofocal is probably going to become superfluous because there's going to be good standard monofocals and premium monofocals. And what's potentially more helpful is single focus and increased range of focus. And within increased range of focus would be premium monofocals that essentially will increase the range of focus that a standard monofocal would give you, such as this lens. And then the traditional extended depth of focus lenses, which are diffractive optics mostly, would all fall into this range as well. Full range of focus being mostly trifocal lenses. This is the defocus profile of trifocal lenses. So it is designed to give you distance, intermediate, and near. There are many more lenses than this now available, but the The principles are very similar, and obviously the RayOne trifocal is an excellent option for patients in whom you feel a trifocal is most suitable. Trifocal lenses are not for everyone. In most patients, nighttime vision disturbance is mild, but in some, not so mild. Patients often adapt with time. But if there are any of these issues occurring post-operatively, then it can create problems for patients. So corneal ocular surface disease, the lens isn't centering well. If there's residual refractive error, these lenses can be quite sensitive to that. Capsular opacification needs to be treated, any macular problems. In general, the lenses, trifocals are best implanted consecutively, which means you have to plan for bilateral surgery. And the patients need a lot of chair time before and after. Which means that there are many patients that the majority of us would avoid using trifocal lenses in. For a start, patients that are happy wearing glasses, you probably wouldn't go down the route of everything that's involved, I just mentioned. Patients that have got recalcitrant or difficult to treat ocular surface disease, irregular corneas, which includes patients that had LASIK many years ago, macular pathology, even in diabetic patients that don't have macular pathology, if you thought they might develop macular pathology, you might feel that that's a relative contraindication. High corneal astigmatism can be problematic, even though they're toric trifocal lenses. If you do end up having any kind of rotation and there's residual astigmatism that induces coma, which can be more problematic for these patients that are very sensitive to any aberrations additional to those induced by the way trifocal lenses work. If you have concerns over intraocular lens centration, such as pseudoexfoliation syndrome, glaucoma, and then cornea disease, such as Fuchs, all of those are not good indications for using trifocal lenses in the hands of most surgeons. So, you know, the what's called extended depth of focus, which I think now falls into the umbrella term of increased range of focus alongside premium monofocal lenses such as the EMV lens, need to be very careful, because the Symphony, for example, the Atlara by Zeiss, they all work using diffractive optics, and the rings basically induce all of the same problems that trifocal lenses do, albeit just with a lower ad power. So they don't get away from those problems that I just mentioned. You have lenses like the IC8, which is a true extended depth of focus lens, but that mask and small aperture can cause dysphotopsia in some patients because of the shadow that it throws onto the retina. But it does work well in patients that have had previous radial keratotomy, for example. So there is a huge market and a huge potential for trying to find some kind of compromise between just using a standard monofocal, which gives no additional intermediate or reading vision to patients. It provides no additional value to patients or to you as surgeons to be able to offer your patients. And then the full trifocal or even diffractive extended depth of focus, which can cause many problems with respect to quality of vision. And I think the spherical aberration principle does address that compromise very nicely. As Sam's already said, positive spherical aberration is a natural state in the human eye. And for that reason, patients are not complaining of quality of vision issues. It's worth saying it's a very small amount of spherical aberration that's built into the lens, but with a small amount of spherical aberration, you get a lot out in terms of increased depth of focus. Interestingly, the negatively spherical aberrating lenses like the Eye-Hance don't seem to give you the same intermediate or reading vision. They do in a small minority of patients. I was using the Eye-Hance prior to using the RayOne EMV because the EMV was only available from October onwards, but I've subsequently abandoned using the Eye-Hance in the majority of my patients because the EMV is giving superior results for intermediate and near without any compromise in distance vision. So I've now implanted well over 100 eyes, but I'm going to talk about our results where we scrutinize results more carefully so I can show you some graphs and some statistics. And we're going to look at individual eyes in 33 for 33 eyes, and then bilateral eyes where the target was emmetropia, and that's 24 eyes. And then I will talk about a small subgroup, which was bilateral eyes treated with mini monovision. So that's more than -1 diopter target in the non-dominant eye. The results of individual eyes with an emmetropic target. These are the demography the demography of this. Most patients are having cataract surgery. Patients were either myopic or hyperopic beforehand. Some patients were emmetropic. 70 years old was the average age. So you can see here that all patients are achieving logmar of distance vision in individual eyes of 0.2 or better, and the vast majority are 0 logmar or better. That's over 80%. And that's just in unilateral eyes. Obviously, the binocular vision is significantly better. Intermediate vision is excellent. So you can pretty much guarantee intermediate vision to these patients. So when you're speaking to your cataract patients before surgery, and they say, look, shall I have a standard lens? You can say, yeah, you can have a standard lens, but there's no guarantee you'll be able to see the dashboard of your car, no guarantee you'll be able to see your watch, no guarantee you'll be able to see your phone, no guarantee you'll be able to see your computer screen. With this lens, 80% of patients are N10 or better, which is equivalent to J8, and 60% of patients are N8 or better, which is equivalent to J6. And that's just in one eye. When you look at the binocular results where both eyes are treated, they're significantly better. And the near visual acuity is very similar actually to the intermediate acuity. So again, you have 60% N8 or better, which is J6, and 80% N10 or better, which is J8. And everyone has some level of intermediate vision. Whereas if you use a standard monofocal lens, at least half of patients are N18 or worse. So they've totally lost their intermediate world and all of their near world. One patient complained of negative dysphotopsia, which is nothing to do with the lens. You see that if you put enough lenses in, you see that in patients in general. And then things like postoperative anterior uveitis and cystoid macular edema, we see that whatever lenses we're using. So it's not really of significance. But none of these patients were, after the first 3 months, no patient was complaining of any quality of vision issues. It's worth saying actually that in over 100 implantations, I've yet to have a patient come back and see me who's unhappy with the vision from this lens. So in the bilateral eyes, slightly smaller group because some patients obviously were only having one eye cataract surgery. But in the bilateral eyes, the vision is more meaningful. The visual results are more meaningful because this is what you'll be doing in the majority of your patients using it bilaterally. And you can see here the distance vision is logmar 0 or better in everyone, and in over half of patients better than minus 0.1 logmar for distance. Intermediate 100% N8 or better, and 70% at N6 or better, which is equivalent to J4. So I don't promise them reading vision, but many of them do have reading vision, and really only require glasses for small print reading, but for social reading, they are independent of glasses, and that's with an emmetropic target. And the near vision, again, 70% N6 or better, and 100% N8 or better. Sam's already covered monovision. It's a well-established, long-studied approach that works very well. We use it very commonly in laser vision correction patients. And many of the disadvantages of monovision don't apply with this lens because it's extending the focal range due to the way it works with spherical aberration. However, it's clearly more forgiving to target something closer to 0 in both eyes and targeting something like minus 1.5 in the non-dominant eye, but there's a middle ground between the two. So the results I showed you were an emmetropic target in both, but there are some patients that are already tolerating monovision in contact lenses or who want total independence of glasses but are not suitable for trifocal lenses, in whom I will target a full monovision, what I consider a full monovision with this lens, which is a target of 1.25 in the non-dominant eye or more. This is one such patient. Target was 1.25 in the non-dominant eye, which is the right eye. Target was plano in the dominant eye, which is the left eye. Patient 6/4 unaided, which is logmar minus 2, 20/12.5 vision. Right eye unaided, 6/18, but reading N4, which is J2. So it can achieve total independence of glasses if you use it in that way. The risk, I suppose, is if there's any unpredictable refractive result in one of the eyes, then the enhancement rate will be slightly higher. And obviously patients have to be able to tolerate a little bit of monovision. But what I now do, in fact, let me just show you these curves. So these are the point spread function and spherical aberration curves. This is a defocus. So this is a non-dominant eye, which we deliberately defocus, but about 0.11 diopter equivalent of positive spherical aberration. Up here, 2.66 is defocus. And then in the dominant eye, you see here, pretty crisp point of light, 0.11 positive spherical aberration again, not much defocus because target was 0, but it's measuring on the aberrometer 1.3 diopters of defocus, and I think that's because that's the extended range of focus that you see with the lens. So that's the additional focal range that it's giving you for very little, if any, drop off in visual quality. Certainly nothing that patients complain about. So what I now do is, in fact, I'll tell you what I'm now doing in a minute, but let me just show you the mini Monovision results. This is more than -1 in the non-dominant eye. This is to show you that you can achieve total spectacular independence. Binocular distance, obviously binocular results here because it's Monovision, but binocular distance vision, logMAR 0 better in everyone, and N6 or J4 better in everyone, 50% N5 or J3 or better, and many patients achieving J2. What I now do, I now target, I don't have results to show you because I've subsequently moved on to doing this, but I now target emmetropia in the dominant eye, and between -0.37 and -0.5 in the non-dominant eye. So I'm deliberately targeting a little bit of monovision in most patients, and it's giving them predominant independence of glasses for everything except for small print reading. You know, and even for those patients that say they're happy wearing glasses, the opportunity to be able to get in their car on a rainy day without glasses fogging up, or to walk around, go to the toilet, be able to see the time on their clock or on their watch in the middle of the night. You know, patients might think that they're happy wearing glasses, but actually being independent of glasses for distance, intermediate and social reading is a huge benefit. And this has increased the premium lens usage in my practice. Prior to this lens, I was using about 25 to 35% trifocal lenses and about 25 to 35% toric. So at least 30 or 40% of patients were not having a premium lens. Now I'm using premium lenses in 95% of my patients, because any of the patients that don't have those lenses are now getting this lens. So it really can increase premium lens usage for many. And there's very little preoperative testing, preoperative counseling or post-operative counseling required. It's a very forgiving lens. And I just congratulate RayOne on bringing something so valuable and helpful to patients to market. Thank you very much. And we'll now have some time for questions.
Thank you very much, Alan. That was, yeah, very, very interesting. I learned quite a lot there. I haven't seen that presentation before. So thanks for your time. We've got questions mostly around how you use the lens and what patients you might need to be cautious about. I've got a question from Mr. Andy Luff in the UK asking what attention, if any, you would pay to centration on the optical axis. Clearly something that's very relevant with multifocal lenses. Is that something that you're concerned with?
No, I'm not concerned about worrying about Purkinje reflexes or things like that with like you would with a trifocal lens. So with a trifocal lens, the central optical kind of distance dominated part of the lens is normally only about 1.5 millimeters. So the concern is that if there's decentration there, they may be, you know, the kind of nodal point of the eye, if you like, might be coincident with one of the rings, for example. This lens isn't like that. Like you say, when you look at it, you don't see any rings or zonal points or things on it like you do with the Vivity lens, for example. You can see the ring on that anterior surface on the Vivity lens, which does give some patients halos at night. This lens really does look like a monofocal. It's just got the positive spherical aberration built into it. If I suspected extensive decentration, I wouldn't use it. And to be honest, I probably wouldn't use any kind of aspheric lens in someone where I was expecting extensive decentration, because they're all relatively unforgiving of large amounts of decentration. So if you're dealing with a patient with significant zonulopathy, or where you've maybe had to use a capsular tension ring, you're probably better off using a spherical lens in those patients. And in someone with pseudoexfoliation syndrome, where I might be worried about a late decentration, I might choose not to use it. The only other patients I won't use it in, a patient that's had previous radial keratotomy, because those patients have very highly positively spherically aberrated corneas, and I don't want to add to that. And then I suppose in patients that have severe corneal endothelial disease, like severe Fuchs, where you know they're going to need an endothelial transplantation afterwards with use of air, I prefer to use a hydrophobic lens. But I pretty much use it in everyone else. Like, there really are very, very few cases where I feel like it's not suitable. I also, at the moment, don't use it in high astigmatism because there's not a toric version of it. But if they have a diopter or less of astigmatism, I find the lens to be very forgiving. If they have less than 1.5 diopters of corneal astigmatism, then I make limbal relaxing incisions or femtosecond astigmatic keratotomies. And if they have more than that, I would just have to use a regular toric lens or some alternative. But when the toric EMV is available, which I'm hoping will be soon, then that will no longer be an exclusion criteria.
Thank you very much. You've actually answered the number of questions regarding cylinder, and what's acceptable. The company line is less than 1 diopter. It sounds like you find that yourself to be about right then. Now, we've got another question here for what happens as we know, with any lens, you can sometimes have a refractive surprise. So Mr. Hubbard in the UK has already used EMV and has had a slight refractive surprise in what was due to be the near eye, and so it's not ended up giving the near vision that that the patient was hoping for. And he's asking, would it be suitable to use a Sulcaflex lens, also manufactured by Rayner? For those of you who don't know, it's a supplementary lens designed to sit in the sulcus, doesn't contact the lens in the bag, and you can correct refractive errors in this way. Would you find that a sensible approach?
Yes, I mean, I wouldn't have any concerns with using a Sulcaflex alongside this lens. If you're trying to induce more myopia, then I think that's preferable in most cases than hyperopic LASIK. If you're trying to induce less myopia, then myopic LASIK is my preference, but Sulcaflex is also a good option.
Excellent. Okay, thank you very much. We've got a couple of polls have gone out, and we're just looking, and it seems that from the answers, occasionally most people are using some level of monovision occasionally, and the most popular level of offset actually is a 0.5 diopter to 0.75, so quite close to where you've ended up actually with your more recent cases, and probably I think where the majority of users of RayOne EMV may well find themselves. But we do have users worldwide using it in a traditional monovision sense, with minus 1.5 or even greater targets in the near eye. And the main message from us is that you should just use a lens, as I say, as you would with your normal monofocal. If you would normally employ a higher level of monovision, then you can do that, and you can have then a direct comparison of the results with EMV compared to your standard monofocal lens. Just having a little look through any more questions. We were asked actually what the EMV stands for, and it actually stands for Enhanced Monovision. So if anyone's wondering what the actual lettering stands for, that's it. In terms of any other sort of summing up at all from you, Alan, before we break, we've got about 3 or 4 minutes left. Would you say that this lens for most surgeons is going to be something that's quite easy to adopt into their practice with the normal equipment that they might have? Do you think it needs any particular pre-op equipment or any unusual measurements, or would you be happy to just use a normal biometer and use it as a standard lens?
Yeah, absolutely. I mean, in our practice, it's a refractive practice, so we do a lot of testing beforehand, but that's totally not required with this lens. Biometry only is fine for those that are working in that way, because the exclusion criteria are so minimal, i.e. there are so many indications where you can use it and use it well. I would say for surgeons that have not used it before, to start off using it with an emmetropic target in both eyes. And then once you get comfortable with it, you can start to push a little bit of monovision in the non-dominant eye if you want to try and give them more reading vision. But just with emmetropia in both eyes, they are gaining intermediate vision, which is valuable to patients, and something that they're happy to pay towards in countries where the lens charge needs to be paid for by patients, which is the case with most premium lenses.
Mm-hmm. I have a question here. I'm asking, given the very good results for near vision with this lens that you've shown are possible with a little bit more monovision, where would you still choose a trifocal lens? What type of patient would we still use a trifocal lens in?
Well, I think that the kind of patients that have trifocal lenses expect to be totally independent of glasses all the time. And the near visual results of trifocal lenses are very, very, very predictable and reliable, i.e. 97 to 98% of patients with trifocal lenses never need to pick up a pair of glasses for anything. So those are the patients where I'd use trifocal lenses, where they do not want to wear glasses at all. For patients that are happy to wear glasses for small print reading, which is many patients because it's not such a big deal to require that, then this avoids all of the hoo-ha, if you like, with trifocal lenses, without the fear factor of quality of vision issues, night vision problems, or anything like that.
We've just had our final poll results. Interestingly, the most commonly used lens that could be considered in this very broad category, as you say, was the iHance, which you've already mentioned your experience with, followed by the Oculentis Comfort or MF20 and the J&J Symphony, which are both, as we said, low-ad multifocal lenses. It sounds like from your personal experience, there's quite a lot of advantages for RayOne EMV over those lenses. Do you see any disadvantages being, to give the other side? Are there times you would use those other lenses now instead of EMV, or do you think that it's overall achieving a better profile?
I never use the M Plus anymore. It causes too many aberrations of vision compared to these other alternatives. The iHance I'll use if I have to use a hydrophobic, like someone with severe Fuchs dystrophy, or patients that have had previous radial keratotomy where I don't want to induce more positive spherical aberration. But that's pretty much it. Otherwise, I'm using the EMV in everyone where I wouldn't use a trifocal. I think this just gives better intermediate, but this gives about 2 more lines of intermediate and reading vision than the iHance used to.
Mm-hmm. And this is a question actually I've been asked a lot of times. We've kind of talked around a little bit, but do you actually recommend checking the pre-op spherical aberration with this lens? I think you've kind of said the answer that it's not really necessary to do that.
No, it's not required at all.
Excellent. Okay, well, thank you very much, Alan, for your time today, and thank you so much for all our many attendees. This video, if you've not been able to join for all of it, or you've got colleagues who might be interested, will be available on the Rayna IOL YouTube channel in the next few days. We'll endeavour to answer any questions that we haven't answered already by email, and we look forward to speaking to you again soon. Thank you.